Dear students, today we'll discuss a very common topic in the abdomen. Just see what is this. See that so much distension. See that so much distension here, and some more swelling is here. So what is this? This is ascites due to portal hypertension. All of you know that portal hypertension is the increased pressure, portal venous pressure, which causes so many problems. Maybe prehepatic, hepatic, post-hepatic causes are there, and that causes the ascites. And because of the ascites, there is weakening of the muscle. Because of the hepatic dysfunction, weakening of the muscle, and that's why umbilicus gives way, and herniation occurs. A very common entity which you can see here, herniation. So with the most of the time this hernia eventually becomes irreducible. So you can see the flank is fullness, dilated vein, something like visible veins you can see, distended, so much distension with the free fluid. So you have to look for the fluid thrill and percussion test to confirm the fluid, and splenomegaly may be there, that you have to look by patient to putting the patient towards the right side, and other examination may require eventually gastroscopy. So this is the typical umbilical hernia with the ascites due to portal hypertension. So gradual distension of the abdomen, features of hepatic failure, all features, jaundice, edema, pleuritis, tiredness, asthenia, muscle weakness, muscle gets weakened actually, and causes of ascites in portal hypertension are hyperproteinemia, increased hydrostatic pressure, lymphatic blockage, altered aldosterone mechanism. So the causes, remember, often asked as MCQ question, and why also they will ask, and maybe a theory in short note, ascites in portal hypertension, what are the causes? You should be able to express these 3-4 causes, which leads into the lot of fluid collection, becomes a massive ascites as such. See that? So what investigation you'll do? Basic is ultrasound, liver function test, CT abdomen, MRI, endoscopy, mainly to find out the esophageal varices, because esophageal varices due to portal hypertension is a cause actually, and if it is there, may cause bleeding and may lead into sudden severe hematemesis, often life-threatening, which requires banding, some intervention, especially endoscopically. Usually medical gastroenterologists will do that. So better to do endoscopy beforehand only, have the idea about the how severe grade esophageal varices is there. If it is so, plan for banding then and there only, so that prevent the bleeding. Even though prophylactic therapy for the varices is controversial, but currently most of the medical gastroenterologists tend to do the banding so that prevent in future, in anticipation of bleeding in due course of the time, especially patient like this. But severe ascites is definitely severe portal hypertension as such. So management, correction of serum protein salt, mainly albumin may have to infuse in these patients, and ascitic tap you may have to do. And they are so much prone for the spontaneous bacterial peritonitis. Sometimes or many times it is appreciated that, or it is advised that better to give some sort of antibiotic, usually norfloxacin in a single dose daily for long time to prevent SBP. Spironolactone is there to reduce the fluid collection in the abdomen, peritoneal cavity. Spironolactone 25 mg orally BD, 25 mg orally BD should be given. So ascitic tap you have to do, how to do, is usually lateral to the lateral muscle, mainly bladder should be empty. Ask the patient to pass urine, otherwise pass a catheter, otherwise your needle may go into the urinary bladder and will cause a complication as such. Then tap, usually when you tap, at a time, tap 1 to 2 liters, that's sufficient, because suddenly if you decompress and splanchnic vessels will dilate, and suddenly there will be hypertension, severe hypertension may cause for a cardiac arrest. Don't allow that. Daily or regularly events, morning to 1 or 2 liters, evening 1 or 2 liters, next day like that. And many times they'll put a small tube to drain the small trocar catheter tubes, and put it there, clamp it, drain regular intervals 1 or 2 liters, so that decompress abdomen. Gradual decompression, that's the point, it's very, very important. Peritoneum venous shunt is the other option. TIFs, transjugular intrahepatic stenting shunt is a very, very useful technique done through endoscopy. And ideal treatment eventually is a liver transplantation. That's the best treatment. It cures everything. Liver function will get retained, ascites get corrected, all other problems will get corrected. So this is the final treatment opted to these such patients. So complications are due to ascites, respiratory embarrassment, umbilical hernia you have seen, with ulceration, skin erosions, spontaneous bilateral peritoneum, you already told, SBP, and most of the time you will give Norflox daily. This is the preferred drug in all these patients by medical gastroenterologist. So that is the topic about the portal hypertension. Very commonly asked a short note, remember. Answer the MCQ. Which of the following gives short-term relief in ascites in portal hypertension? A. Spironolactone, B. TIPS, C. Ascitic tap, D. Liver transplantation. So students, go through my SRB's clinical methods in surgery, which has got a video lectures of each topic. So many topics are covered. Every topic as far as CBM syllabus is covered. How to examine the patient. Swelling, ulcer, arterial disease, venous disease, thyroid, breast lump, mass abdomen, briefly orthopedic, every system, whatever your required thing, everything is covered. There is a video of how to examine of each topic, and principles of examination is good, and differential diagnosis in the table format is given, and briefly investigations. Of course, treatment is not a topic will be covered in a clinical method examination, remember. And many photos of the most of the conditions with the illustration. Photos will tell the clear idea about for the students how exactly condition looks like. So covers everything with the beautiful photos, and it also gives the instruments, specimens, then operative surgery briefly. Everything is covered. Small images also it is covered. So it is more than sufficient for all undergraduate, postgraduates of any system to learn. Very basic required thing for the surgical field is clinical methods. So please go through that and purchase that and make use of it. My SRB manual of surgery is very popular. It covers theoretical aspect, everything, principles, treatment in detail, briefly technical aspect, and with the photos, illustrations, quotations, all topics with the specialty, urology, cardiothoracic, neurosurgery, and operative surgery instruments. Again, it is covered in this book also. Every quotations, and you should worldwide also, actually including our country, everywhere. And please, you can make use of it. My operative surgery book, SRB's operative surgery atlas, that is a 2-volume book, covers in detail operative technique of surgery, all surgery, small surgery, major surgery, everything, with total around more than 10,000 illustrations and photos. It gives very good principles and technical, step-by-step technical aspect. Very useful for postgraduates. Not much useful for undergraduate, but it's a postgraduate book and consultant book and learner after MS. It gives everything. You can, before going to surgery, you can always read this book and memorize your steps and do the surgery properly. Every topic, general surgery, gastroenterology is covered in detail, step-by-step with illustrations. And my SRB's atlas of tissue approximation, small book atlas, 100 pages, how to do the suturing, tissue approximation, including laparoscope suturing with the video. It is covered. So any basic learners, suturing is very important surgical field as a skill actually. Dissection and suturing, so the two parts of the surgical skill. So that is also covered very well with videos. You can always go through that. And my website, please subscribe, all of you. Your daily lectures are there, live sessions are there. My Diginour lecture through JP Publishers, around 220-hour lectures. Entire thing as for CBM is covered with the examination part, with all topics of CBM, ulcer to operative surgery, instruments, specimens, examination, specialties, basic, everything is covered. You can always purchase for 1 year and have a clear idea about the surgical topics, understand very well, and helpful for your exam, NEET, MCQs. Also, it is there both in manual and my lectures. So students, I hope you have understood this lecture very well. Thank you very much.